about electrodiagnosis in autonomic nervous system. So moving on to the topic. So my scheme of presentation will be today I will tell about briefly about the introduction of the autonomic nervous system and the classification of autonomic nervous system and the various electrodiagnosis method in identifying the autonomic disorders, and finally about CAS score, and I will end it with a summary. So introduction. So what is the autonomic nervous system? So why it is needed means it is maintains the internal homeostasis without our consciousness. So it is not under our voluntary control. It is needed for the internal homeostasis. So it is needed for every physiological process that occurs inside our body. So mainly the autonomic nervous system is classified into sympathetic nervous system, parasympathetic, and another one is that is enteric nervous system. Sympathetic is like flight or fight response. It is like hyperadrenergic state, and parasympathetic will be like when we are relaxed, rest, the parasympathetic will be activated, and moreover like digestive. And the next is about the enteric nervous system, and it is independent regulation of a digestive process. So we have main three classifications. So coming on to the sympathetic. So as of all we know, sympathetic outflow, it is a thoracolumbar outflow. So it occurs from the intermediolateral causal column, and from that it reaches the preganglionic ganglion and the postganglionic ganglion with a parasympathetic trunk. So the sympathetic trunk will be lying that paravertebral region. So preganglionic will be like the neurotransmitter will be acetylcholine, and the postganglionic it is mostly norepinephrine, except in the sweat glands it will be the acetylcholine. The main receptors for sympathetic nervous system will be the alpha and the beta adrenergic receptors. And the functions of the sympathetic, so all we know. So main thing is like it's like flight or fright response. In heart, it increases the heart rate and contractility, and suppose in respiratory system, it causes bronchodilation, and in eyes, it causes pupillary dilation, and it increases the BP by causing increase the peripheral vasoconstriction. When it comes to GI, it will be the opposite to parasympathetic. It will be like decrease the gastrointestinal motility and secretion, and in bladder, it is like storage function. So it is also responsible for sweating. So the sweating alone, there is a final receptor, final neurotransmitter will be different, acetylcholine, and other most of the things it will act through norepinephrine. And parasympathetic is craniosacral division, that is craniosacral outflow. The main cranial nerves are like 3, 7, 9, 10, and spinal segments from S2, S3, S4. So here the in sympathetic, the ganglion will be the very near to that vertebral region, but in parasympathetic, that peripheral ganglia will be near to the organ it going to supply. So it is has long preganglionic fibers and short postganglionic fibers. The main neurotransmitters here is mainly acetylcholine, both presynaptically and postsynaptically. And the receptors, as we all know, it is like two types, nicotinic and muscarinic receptors. So it acts opposite to sympathetic. So when we are relaxed and calm, it comes to act like it reduces our heart rate, it reduces our blood pressure, and mainly in GI tract, it increases secretion and increases the bowel motility. In bladder, it helps in the voiding. The main important functions. No, there is another one set like enteric nervous system. So we are classifying into subcategory because it functions independently. There is separate pacemaker cells, and it has separate plexus like myenteric plexus and mesenteric plexus. So myenteric plexus is need for motility of the GI tract, and mesenteric plexus controls the secretion and the blood flow. So then the main neurotransmitters here are like acetylcholine, nitric oxide, serotonin, and ATP. Mainly regulates the GI motility along with the parasympathetic nervous system. It mainly helps in peristalsis and segmentation and secretion, mainly needed for absorption of food particles. And it also has gut-brain axis, some role in immune and endocrine system also. So here you can see the myenteric plexus will be inside that it is named because it will be like inside the muscle layer, and submucosal will be laid in the submucosal region. So myenteric is mainly for motility, and submucosal is for mainly for secretions and controlling blood flow. Then, so what controls all this? So as we told, sympathetic has thoracolumbar outflow and parasympathetic craniosacral, and there is a separate called enteric nervous system. So everything is interlinked and controlled by central autonomic network. There is not a single center. There is multiple centers. They will work interlinked. For example, the main center is a hypothalamus. So it is the highest command. So other than that, it has multiple nuclei around the limbic structures like amygdala, insula, anterior cingulate. Suppose we get some, we are seeing some frightful situation. We got increased sweating, heart rate. It's due to emotional triggered increased heart rate. We're getting fear. So this and all mainly due to this limbic structure nuclei like amygdala, insula. So this during that process, this nuclei and all come in role. And another thing is like brainstem nuclei like nucleus tractus, solitarius, and dorsal motor nucleus of vagus and ventrolateral medulla. How it helps means, suppose we have the respiration we are normally doing, so it is sensed by that our baroreceptors, vagal nerve. So vagal nerve sends input to nucleus. So the front of vagal nerve it reaches finally nucleus tractus solitarius, and it has link with the higher center of the autonomic nervous system, and it reflexly either it increases the heart rate or increases the heart rate based on the reflex mechanisms. So from this, majority fibers project to the brainstem and spinal cord, and it occurs interconnection with sympathetic and parasympathetic neurons. So it works in some interlinked manner and maintains our internal homeostasis. So as I already explained, it is like integrating cardiovascular, respiratory, thermoregulatory, and emotional response. So maintains homeostasis via feedback from baroreceptors, chemoreceptors, and visceral efferents, and maintains balance between sympathetic and parasympathetic tone. So it is a basic of the autonomic nervous system. What are the autonomic system? What are the things we have in our body? And suppose if it fails, what happens? So causes of autonomic failure, I will tell it in a brief manner. So main thing we can classify to whether it is pure autonomic failure, that is means only having only autonomic failure alone. Otherwise, it is autonomic failure associated with other like Parkinson or ataxia, or autonomic failure associated with peripheral neuropathy. So when and all you can have like pure autonomic failure. So when the pure autonomic failure occurs, suppose the autonomic that sympathetic or parasympathetic ganglion get affected, the pure autonomic failure occurs, such that in autonomic gangliopathy, paraneoplastic autonomic gangliopathy. So as all we know in subset of Parkinson disorder, multiple system atrophy and Lewy body dementia and are associated with some autonomic disturbances. So here that because this is a chronic degenerative process leading to multiple system atrophy along with degenerative autonomic process also. So in this also it can autonomic failure can accompany. Other things like if you take into example of peripheral neuropathy, like think of example of like Sjogren syndrome, paraneoplastic. It will cause affect the peripheral nerves along with the autonomic mind fibers. The common thing we think like distal sensory motor type nerve, diabetes and amyloidosis. It will affect the peripheral nerves along with the autonomic nervous system. Other things are like vasculitis and infectious causes like HIV, hereditary cause of pain also cause along with peripheral neuropathy it can cause
പത്രം വായിച്ചോളാം
failure. Other
വായിച്ചോളൂ
causes may the
ശരി
main thing we have to
വിഷമിക്കാം
consider when if a patient comes to with the autonomic disturbances, we must we must think of common things like suppose we must also rule drugs like alpha and beta whether they are on any drugs. There are common causes leading to orthostatic hypotension, and other thing like infections also we have to think about. And the last we get is think of at least like a hereditary causes like hereditary sensory motor autonomic neuropathy, Fabry disease, and sometimes it can cause idiopathic and it can occur in sodium channelopathies like SCN9A and SCN10A channelopathies. So now moving on to the topic proper. So I have just given you only brief about autonomic nervous system. The main topic is about what are the tests we are doing to identify the autonomic disturbances and how we are going to think. So the test can be grossly divided into whether we are looking for like a parasympathetic, like audio vagal tone we are checking, or we are checking for sympathetic vasomotor test, or in sympathetic also whether we are getting specifically that test for pseudomotor that are like associated with test for sweat glands. Coming to the parasympathetic test, there's a main test are like heart rate variability during deep breathing and Valsalva ratio. That is Valsalva ratio only parasympathetic base. So Valsalva test can be used both identify parasympathetic and sympathetic dysfunction. That is both because Valsalva has both parasympathetic and sympathetic base. And this for sympathetic things are like heart test, isometric hand grip, and cold pressure test. The laboratory important tests like for sympathetic pseudomotor test are like quantitative pseudomotor axon test and thermoregulatory sweat test and sympathetic skin response. Sympathetic skin response are commonly available in major main thing. QSAT and TSTS is available in only rare centers, not available everywhere. So first I will move on to that like parasympathetic test, that is heart rate variability with breathing. So what happens when we deep breathe? As you know, during inspiration, the heart rate increases, and during expiration, the heart rate, the parasympathetic thing acts, and it causes our heart rate gets decreased. So there's a widening of RR interval during the expiratory phase. So we have to take an expiratory into inspiratory ratio of that is that RR interval ratio during expiration and shortest RR interval during inspiration. So normal ratio will be more than 1.2. It indicates what it indicates means. So if there's a proper vagal control of heart rate, there will be during expiration the heart rate will become less such adequately. So when we calculate RR, that the longest RR interval, and when we divide it by shortest RR interval in inspiration, so we will get a ratio for normally we'll get more than 1.2. So if the ratio is less, if the ratio is less, it indicates some parasympathetic dysfunction. So this is a next important test. We have to do is like head up tilt test. So here what we are doing, what we are actually finding is first there are two phases. We have to first patient must be in that table will be supine patient. The patient will be lying supine position for 5 to 10 minutes, and the baseline heart rate BP obtain heart rate and BP will be obtained. Then we will slowly passively head tilt the patient with the angle of around 60 to 70 degrees. For minimum we have to do in the tilt phase, we have to patient must be there for 20 minutes. So the maximum can go to 20 to 45 minutes. So what happens when we tilt the patient? So venous, every blood will get pulled up into the legs. So venous return will increase. Venous return will decrease. So blood will get pulled into the leg when we tilting, and the venous return to the heart will decrease, and there will be a reflex heart rate increase in heart rate, and there will be an activation of sympathetic thing. Normal persons will have immediately what happens means within 3 minutes there will be a heart rate will be increased by 10 to 20 minutes, and systolic blood flow due to initial pooling of venous blood in the venous nerve system there will be slight fall, but that must be less than 20 millimeter mercury only, and diastolic fall will be only less than 10 millimeter of mercury. When it fails, it indicates there's a reflex sympathetic vasoconstriction failure. So physiology how it occurs means so when the venous get trapped into our leg, the venous return decreases and the cardiac stroke volume get decreases. So that time what happens? It is sensed by carotid sinus and aortic arch. Normally it will be repeated. It will be increased fire when it causes increased fire. When it is stretched, there will be increased firing. When the venous blood, when the blood flowing through that thing decreases, the stretch decreases, and there will be inhibition of the firing from this sinuses. So like receptors. So it will when there is a decrease in firing, the vagal tone get inhibited, and it reciprocally activate the sympathetic tone, and it leads to increase in the heart rate and peripheral vasoconstriction. Main thing we are identifying head up tilt is, as I told, normally what happens, I told, initial 3 minutes there will be a mild fall in sympathetic blood pressure and diastolic blood pressure, but due to next activation of the sympathetic when it come to road, finally it at the end of 20 minutes there will be a diastolic blood pressure will be there's an increase by mild 10 millimeter mercury or more, and the heart rate will get increased by 10 to 15 minutes 15 beats per minute. So it is a normal thing. Suppose the patient has dysautonomia. So what happens? There's a reflex that sympathetic thing won't activate, and there will be a continued drop in systolic and diastolic blood pressure, and also there will be no increase in heart rate also. Then what happens in orthostatic hypotension? Orthostatic hypotension is common, so it does not always indicate. First we must understand orthostatic hypotension was first does not always indicates like failure of autonomic nervous system, because it can occur in common like dehydration. We are having very dehydrated also. That autonomic hypotension can occur. Autonomic hypotension, the definition is like when we check with after the tilting, standing within 3 minutes there will be a systolic blood pressure must fall only less than 20 millimeter. If it falls more than 20 millimeter mercury, or diastolic blood pressure fall more than 10 millimeter mercury, it indicates orthostatic hypotension. Now another important thing is neurogenic syncope. So the main thing vasovagal comes here only. So here what happens is like if there is a you increased, it is a reflex activity. Suppose a vasovagal reflex, what it happens means there will be initial I told there will be initial sympathetic activity, there will be increase in heart rate and diastolic blood pressure increase. So some patients will have that increase due to increased vagal tone. Reflex when vagal get activated, it causes bradycardia, and it causes sudden drop in blood pressure. It's a delayed which occurs 10 minutes after testing. So this is the during this phase the patient get syncope. So the main thing is we are testing for head up tilt for for syncope only, for vasovagal, identifying vasovagal syncope. I will explain it in detail. Then other thing is about POTS, that is postural orthostatic tachycardia syndrome. Here there's only increase in heart rate alone. There is a reflex increase in 30 beats per minute, and but there is no increase in BP, diastolic BP. That the tachycardia, but that increase in heart rate is very high. That's more than 30. So it occurs due to the peripheral sympathetic fibers failures. So there is not no proper peripheral constriction. So due reflexively, there is a high adrenergic state, increasing only the heart rate. So the patient, whenever the patient stands, the patient feels palpitation and has increase in heart rate. Here, just see here. Here in normal head up tilt test, so the moreover the everything will be only there is a mild change. There will be initial mild fall in BP, and there will be a sustained. Finally, at the end, there will be a mild increase in diastolic BP. It's a normal process. What happens in see here autonomic failure when here it when patient is in rest, when the patient is get tilted, there's a fall in BP. So it doesn't even pick up. It doesn't even come to bear again. Try to correct. The corrective mechanism is lost. So there will be a fall. There will be a fall in BP completely. So during that full of tilt test. So I told the main thing we are checking for vasovagal syncope. We are going to identify that the patient goes for vasovagal syncope. So we can reflexively stimulate. We can use a pharmacological triggers also can be helpful. Because sometimes I, for the patients to easily identify we can give a pharmacological trigger and we can induce the vasovagal thing. Suppose that's like when we give nitroglycerin, sublingual nitroglycerin, it causes the vasodilatory part, and when that's vasodilation, there will be a reflex thing will be there. Reflexly, sympathetic activity will be there. As I already told, vasovagal syncope is it's a secondary reflex. That is how after the it's a delayed phase. After 10 minutes of the correction phase, the patient will get increased vagal tone and it will lead to cardio inhibitory status, bradycardia, and decreased blood pressure. So another thing is how isopretinol. Isopretinol, how it helps means it like mimics the sympathetic. So it increases the heart rate. When the heart rate get increases, the C fibers of the heart rate will get activated, and it stimulates the vagal thing, vagal tone, and the secondary vagal tone. The reflex vagal tone finally decreases the heart rate and leads to vasovagal syncope. So so if the patient is having syncope, vasovagal syncope, we can divide it into I said there are many findings we can identify from the head test. I said told first we can identify orthostatic hypotension, then neurogenic that is a vasovagal syncope, then dysautonomia. So from when the patient has vasovagal syncope, it can be the response can be classified into three. That is mixed response. Hmm? So the responses of the vasovagal syncope can be classified into mixed, cardio inhibitory, or vasodepressor. So it is classified based on the vasovagal syncope international study classification. What happens in the vasovagal syncope? As I already told, there's a due to reflex vagal tone, there's a decrease in heart rate, and second thing is there is a decrease in blood pressure. So when is the mixed responses? There is both fall in blood pressure and fall in heart rate. So everything in every response it will be there, but the fall in heart rate will be less than no less than 40 minutes. That the heart rate will be more than 40 minutes per minute. Along with that, there will be no asystole occurring. That is like a mixed type. Then in cardio inhibitory, that is cardio inhibition with asystole and cardio inhibition without asystole. So without asystole, here the heart rate, the main thing is heart rate falls less than 40. And if there is associated with the asystole, it is cardio inhibition with asystole. If it is not associated with the asystole, it is cardio inhibition without asystole. And final thing is vasodepressor. That's only there's a BP alone falls very less, but the heart rate doesn't fall that much less. The heart rate fall will be only less than 10%. So in all the three, there will be both falling heart rate and BP. But based on which falls, which has predominant thing, this classified into mixed response, cardio inhibitory, and vasodepressor response. So this is about the HUD test. So the main thing we have to remember in HUD test is it is mainly to identify like sympathetic drive, and also the second thing is about two patients with identify the patients who have symptoms of vasovagal syncope. The second test, main important test is like Valsalva. So what happens in Valsalva manner? Here we are doing we are giving what is Valsalva manner? It is a forced expression against the closed glottis. Also, it can be tested in the lab. We can ask the patient to blow the till 40 milliliter mercury in BP cuff and keep them for 10 seconds. It is similar to that post express we are doing clinically. And what happens during the Valsalva maneuver? There's a four phases in Valsalva. I will explain in detail every phase. First, when we blow fully, when we do forced expiration, so first phase is like onset of strain. When during the onset of strain, initially there will be a sorry, transient increase in BP due to and then heart rate will be moreover stable that time. So why it happens when we start training, there will be blood will be ejected from thorax into the aorta. So there will be transient increase in BP. And second phase can be divided into two, early and late pressure. So when the intrathoracic pressure increases, so naturally that venous return get reduced. So due to with reduced venous return, what happens? So stroke volume will get reduced and the BP systolic blood pressure will decrease. So reflexly, heart rate will increase. That is in the early phase. So in late phase, the prolonged thing will be there will be compensating. It will start to occur, partial recovery will start to occur. The decreased blood pressure will start to rise. So in the second phase, the BP will start to fall here and the reflexly heart rate will increase. And then in the common set in the late phase, the BP will start to come to normal. But heart rate will be there will be sustained increase. Due to sustained increase in heart rate, the BP tends to normal. Then third phase is release of strain. When we stop this, so what happens suddenly? So suddenly what happens? We take inspiration. There is a sudden expansion of chest. That time there will be a transient mild fall in BP dip will be there, and heart rate will be more or less in the heart increase only. So next, what happened? Recovery phase. In the recovery phase, so we have stopped the Valsalva. So in the final phase, there will be venous return, everything will increase, the blood output will get increased. So reflexly, the way parasympathetic get active, there's reflexly that heart, there is what stroke volume get increased, and that BP will increase above the baseline. That's the overshoot of the BP. That is the final phase. When the BP overshoot, what happens? That increased BP will reflexly stimulates the parasympathetic and will cause the reflex decrease in heart rate. That is it comes to heart rate will become decreased. So that is the final fourth phase of the Valsalva maneuver. So here it's a graph. So here you can see in the first phase there will be a transient increase in BP, and the second early phase there will be a fall in BP, and second late phase there will be common that it tends to correct. Then in finally third phase again there will be a fall in BP when the chest expands, and then it will that pressure that after that there will be a overshoot of the BP. So here that there are two graphs. First is like here it see. Here in the A, you can see there is a first initial increase, and there will be a mild, there's a fall in BP. Then there is a mild, in the late phase, there's an increase in, and finally third phase, fourth. Every four phases are present. So it is a normal thing. If you see here, there is only first phase is there, and when the second phase starts, there is no next, the third, second, the late phase of the second is absent. Also, there is no overshoot in the fourth. So it indicates autonomic failure. So absence of overshoot and it indicates there's a no indicates the autonomic failure. So for normal persons, we must have all the four phases. So based on the waves, we can classify it into the waveform can be classified into sinusoidal response, absent overshoot, or square wave response. So as I already explained, it's normal wave. See, imagine if we have that now when we have four phases, it will look like a sinusoidal pattern. It is a normal response. When there's an absent overshoot, the waveform will be, it will go drop and there is no overshoot. So this occurs in autonomic failure. Also, there is called square wave response. Here, that is like square wave pattern. That moreover, the graph will remain flat. So it occurs in cardiac dysfunction, constrictive pericarditis, and cardiac tamponade. Why it occurs? So in normal, if there is all four phases are there in healthy if the patient's healthy autonomic system and cardiac function, there will be a proper sinusoidal response will be there in the Valsalva maneuver. If the patient cardiac issues like constrictive pericarditis, the response will be very flat. There will be no up and down. So they will have the flat response. So like square wave, there will be a increase in it will remain moreover same in all phase. Then absent fourth phase of that is absent overshoot indicates sympathetic arrhythmic failure, autonomic neuropathy. So it is mainly seen in neurological disorder like multiple system atrophy and pure autonomic failure, or it can also disorder other autonomic dysfunction like in diabetes and amyloid. Suppose if there is a prolonged BP drop, prolonged BP drops and remains in even in phase 3 and phase 4 also, it indicates same thing like severe dysautonomia and delayed orthostatic hypotension. Similarly, when I told deep breathings that we have found that on heart rate variability test, we have found the ratio. It is similar to that ratio only. So in parasympathetic phase of the Valsalva, we can identify the Valsalva ratio. That is longest RR interval after the strain. And that is in phase 4 by the divided by the shortest RR interval during the strain. That is phase 2. So it is similar to heart rate variability. So normal range must be like more than 1.2 in a. Suppose if there is a reduced ratio, it indicates impaired parasympathetic vagal function. So there is a improper cardiovagal dysfunction. That is cardiovagal dysfunction is there. Next test we are thinking is about cold pressure test. The cold pressure test is mainly identify the sympathetic activity. So what happens here? We have to ask the patient to immerse the hand in the cold water and keep it for around 3 minutes. Mainly the temperature must be less than 10 degrees Celsius. That will be 4 degrees Celsius to 10 degrees Celsius. We must keep for 3 minutes and we must ask the patient to take it. So what happens when we stimulate the hand with cold? It activates the pain receptors. So it activates our pain receptors and it go and stimulate the sympathetic response. So when the sympathetic response get activated, increase the blood pressure and heart rate. So normally we have to see the diastolic blood pressure. The diastolic blood pressure, there must be a rise in minimum of 15 millimeters mercury. If there is if there is no proper 15-degree rise, it indicates some sympathetic adrenergic failure. Now, another thing is isometric hand grip. It is similar to that. Here we are asking the patient to hand grip, like similar to we are doing exercise. You have to there is a specific instrument, a hand grip dynamometer. So we must ask the patient to do maximum contraction for 3 to 5 minutes. During that time, that sympathetic activity gets occurs, and here also the diastolic blood pressure must increase more than 15 millimeters of mercury. The problem with the test is here sometimes that when we ask the patient to do exercise, the patient may sometimes activate Valsalva. They will strain and may do Valsalva instead of that. So it can bias the test. So we must be careful in that. Now another thing is mental arithmetic test. It is a simple bedside test we can do. So here what we can do is we have to ask the patient to serially subtract. So during the mental act. uh, Arithmetic spelling. Mm, mm, sorry. IRI. So, performing serial suppression, we have to think. So it activates the sympathetic outflow. It causes increase in systolic blood pressure. Normally, the systolic blood pressure must increase by 10 millimeters mercury. If there is no proper sympathetic activation, the blood pressure won't rise more than 10 millimeters mercury. So there will be more false positive and negative things can happen in these kind of tests. Mhm. So next thing I will tell about is the sympathetic pseudomotor function. Uh, what we are testing here is like, so in sympathetic system, in sweat-well gland has special things like it's like postganglion sympathetic fibers that are called pseudomotor neurons. What happens is it is a neurotransmitter will be here different. That is acetylcholine. Here what we are mainly testing is we are testing the sweat production. So if there's intact, the hypothesis, if there's an intact sweat production, proper sweat production, that sympathetic adrenergic neurons of, sorry, the sympathetic neurons are intact, postganglionic sweat pseudomotor neurons are intact. So there are three types of tests. One thing is like quantitative pseudomotor axon reflex test, and another thing is thermoregulatory sweat response and sympathetic skin response. So when in the small fiber neuropathies with the failure of the autonomic mechanism, this can get affected. So for example, in diabetic and amyloidosis and neurodegenerative dysautonomous like MSA and pure autonomic failure, this can get affected. First thing is about sympathetic skin response. How we are testing this? Here we will keep the surface electrode over the palms and soles, and we'll give you electrical stimuli over the other hand. So we can give you some sensory like low sound. We have to activate, or we can give you some electrical stuff. So it will induce a sympathetic response. So when the sympathetic response get activated, there will be a change in skin potential, and there will be a sweat. The sweat production will be that identified that when the neurons get activated, the change in potential will be measured by our electrodes. So if there's a that the autonomic pathways in that pathway, the integrity of it tests the integrity of autonomic pathways. If the pathway is very intact, there will be a normal SSR response. We are giving in the lab in our lab we are giving current electrical stimulus. Large sounds we will give patient like the sounds.
What together, we were shocked along with them also. So you are going to accept it. And one after the other. It's very, they clap. They make us laugh and they give their big shock at the same.
To accelerate it, we can give the combined stimulus like both along with both electrical and sensory stimuli like sounds. We can combine and give. Oh, the normal response will be like the normal SSR waveform will be like biphasic, either initial negative and followed with positive deflection, and are like opposite. The waveform amplitude can vary. The main thing is we are identifying whether the waveform we are getting. Here we are not mainly concentrated on amplitude, whether we are getting that biphasic wave. That is important. Other thing we must check is latency. Normally it will be less. Normal persons will get this response within 3 seconds. So in normal SSR, there will be clear identical peaks must be there without excessive other background noise, and latency will be between 1 to 3 seconds. Suppose there is a prolonged latency or we are not getting this way, it indicates autonomic nervous system dysfunction. So main usefulness of this test is to identify small fiber neuropathies and autonomic neuropathies, mainly affecting sympathetic pathways. The common thing we are seeing in the clinical practice is diabetic small fiber neuropathy. The SSR will be absent. Also in autonomic dysfunction, this SSR will be absent. So next thing we are thinking is that's quantitative pseudomotor action reflex test. Here what we are giving is we are as the name indicates, we are quantitatively measuring the sweat. There are capsules called QSAT capsules. We will place it in the sweat producing that example in hand. We will produce that capsules, and we will here we'll give what we are giving is we will directly stimulate the postganglionic neurons by stimulation of sweat glands on the stimulus by ionophorosis. So when we stimulate, there will be secretion. If there's a proper storage of acetylcholine and the postganglionic neurons are intact, there will be a secretion of acetylcholine and the sweat will be produced. Usually studied in multiples, like we can stay forearm, proximal and distal leg and foot. We can study this thing. It is a quantitative, so it measures the volume of sweat also produced, and it can also tell the latency of the sweat production. It provides both quantitative and qualitative data of the pseudomotor function. So this test is only for integrity of the postganglionic neurons. So only when the postganglionic pseudomotor neurons get affected, the QSAT will get affected. Another thing is thermoregulatory sweat test. What we are doing here is like it is like we are increasing the temperature of our body. So when the temperature increase, our body will reflexively will stimulate the increase. It will cause increased sweating to cool the body. So by that we are producing the sweat. So here it tests the integrity of the whole autonomic pathway from the periphery to the center, not only postganglionic thing. So even when there's the test will be abnormal in both central autonomic dysfunction and both in peripheral postganglionic dysfunction. So there's a special room for this test, and the patient will be lying in the humidity control chamber. So they will we will increase the temperature of the room, usually to maximum of 45 to 50 degrees Celsius. So the main concept is we must increase the body temperature by at least 1 degree Celsius. So from 37 to 38 degrees Celsius. So when we do this, the maximum setting will be achieved in 30 to 65 minutes. So what happens is we are checking here. So it is that we are coating the patient with some dye, like alizarin, like or iodine starch. We can cornstarch. We can coat the patient. So if there's a normal sweat production, the sweat will change the color of the dye. So if we have normal sweating, that yellow color will change to purple color. That is a thing. If there is no color changes occurring properly, it indicates absence of sweating and there is a dysfunction of the pseudomotor dysfunction. So it can happen in, as I already told, abnormal TST can be seen in both both central autonomic dysfunction and in peripheral autonomic dysfunction, like small fiber neuropathy, like diabetes mellitus also. Here one case, just I'll explain with a case. Here a patient with developed Parkinson, with the history of Parkinson at 60 years of age, followed by he developed autonomic involvement with orthostatic hypotension and urinary incontinence. So here the TSC test can be done. Here you can see after 30 minutes of testing. So you can see there is no change in color except over the acral end of the hands. So it indicates only in the acral area the sweating is preserved. So other area the sweating is absent. So this kind of thing this is classical of multiple system atrophy. So it shows global anhydrosis. The MSC, the main problem is preclinic central pathways, along with relative preservation of that acral sweat neurons of the acral sweat gland region. So it indicates selective preservation of sympathetic pathways of greater sweat gland density, that is in palms. So selective sparing of the early selective sparing of the palms with anhydrosis of all other body with patients with a history of like Parkinsonism, we must think of a multiple system atrophy. So these are the main tests as I told. So we have seen the test for adrenergic system. We have seen the test for parasympathetic, and we have seen the test for pseudomotor. From this, they have formed a score like composite autonomic severity score. That is from 0 to 10 scale score. Like they are quantifying the degree of the autonomic failure. That is based on the test we saw till now. That's based on this. The score it ranges from 0 to 10. So if there is a higher score, it indicates severe autonomic failure. If there is a mild score, if there is less than 3, there is mild or no failure. So this is the main thing. So the components of here the pseudomotor index, adrenergic index, and cardiovagal index. Pseudomotor index we can calculate from either QSAR test or TST test. If there is a patient has normal response, we will keep lower score 0. If a patient has abnormal response, we will give the highest score like 3. So if the patient have suppose if the score is 3, the patient will have abnormal sweating less than 50% in 2 or more sites. That is our unhydrosis more than 50% we can tell. So that will have more 3 higher score. Similarly, in adrenergic index, if the patient with 3 and 4 highest score will have, there will be a more pronounced phase 2 decrease. That is a decrease more than 40 milli pronounced fall in phase 2 degree will be there. There will be that, or there will be absent overshoot like that. In cardiovagal, that based on the heart rate, we are checking that heart rate variability due to deep breathing and vagal ratio calculated by Valsalva. If both are abnormal, we will give higher score 3. If either one thing is abnormal, we will give 1 or 2 score. So if the main concept is there is higher score is for the higher dysfunction. So totally we will add all 3. So when the score is more than 5, I think it indicates autonomic dysfunction. If the score is very less than 3, it is doubtful. It is our normal patients, or it will be like mild autonomic dysfunction. So these are the tests we are till now identified and we are routinely doing actually. Then now there are new tests we are coming into the practice that is based on some research purposes. So some of the newer research based tests, I'll tell briefly about some of the tests. That is microneurography. Here what we are telling, they are telling it's a gold standard test. Here what we are checking is we are checking the postganglionic sympathetic nerve activity. What we are doing is we are checking the inserting the tungsten microelectrode into the peripheral nerve vesicle, and we are checking the vasomotor tone, that is like into the blood vessel. Then we are selectively testing the nerves supplying the blood vessels. So why we are that means, so the blood vessels is the main thing for vasomotor tone. So mainly we are thing is like peripheral postganglion sympathetic vasomotor tone we are checking here. So now recently at ultrasound guided base we can properly keep. So I'll explain here. So here what we are checking is like we are properly inserting the tungsten electrode into the nerve vesicle, and we are checking the sympathetic response of the nerve. So during if there's a proper sympathetic activity is there during each heartbeat. Suppose we are having heart the proper every heartbeat there will be a burst will be produced here also. That will be measured here. Here you can see that it's a raw burst. So it can then through the computer analysis we can make into a proper waveforms we can be checked. So it occurs after 1.2 to 1.4 seconds of every R wave of ECG. Main thing we have to understand is in your after every heartbeat, there will from corresponding to it, there will be a burst production. The three things we can calculate: burst frequency you can calculate, or burst incidence, that is burst per minute and burst per 100 beats. The total activity, mean burst amplitude, and total number of bursts we can calculate, and we must correlate with ECG and integrated MSNA test. The main thing we are checking is here the intact sympathetic activity. So when there's a proper sympathetic activity, there will be a proper burst production will be there. So when there's no sympathetic, suppose such as in pure autonomic failure, when there will be a sympathetic activities get degenerated, so that time that mesna will be absent. So here you can check. See, this is sympathetic the nerve and thing. From here, the nerve vesicle, we are measuring the sympathetic burst. So for every heart rate, there will be a that adrenergic norepinephrine will be released. So when that thing is released, there will be a corresponding burst production. So in sympathetic degeneration, this burst production will be absent. When there will be high sympathetic rate, contractile, there will be high sympathetic nerve activity. Suppose we have patient with some insulin resistance and obesity and metabolic syndrome and all, the patient will have high sympathetic drive, and patient with CKD and high hypertension, the patient will have high sympathetic drive. This kind of patients will have a high MESNA. Also in, where are the other conditions for high sympathetic activity like hypothermia, catecholamine test. So this test directly we are measuring the sympathetic activity. So it is considered as the gold standard test. So other tests now commonly on research processor like pupillometry, that checking the pupil size, dilation and constriction to the light and darkness. So thereby it checks the sympathetic and parasympathetic. The lower body negative pressure means it is like artificially we are pooling the blood. So the leg will be placed in the closed chamber, and there will be a vacuum. Due to that, that blood will get pooled in the lung. Similar to like head tilt test only. Like here we are doing with some vacuum thing. Then modified Oxford test, here it is like directly measuring the baroflex sensitivity of the sensitivity. Like we are giving pharmacologically giving drugs, and we are manipulating the blood pressure and recording the baroreflex sensitivity. That is the sensitivity of the baroreflex receptors, carotid sinuses. That and all we are directly measuring with that by pharmacological method. And other tests like we can do an airtel function test. These are the tests we can do other tests for testing the autonomic nervous system. So basically, the main thing we have to understand is that the autonomic nervous system test can be parasympathetic, sympathetic, and pseudomotor. In parasympathetic, the main thing is heart rate variability and Valsalva ratio. And sympathetic, main test we are seeing is like heart and cold pressure isometric and sympathetic phase of Valsalva maneuver. And pseudomotor test will be like thermoregulatory test and quantitative pseudomotor axon reflex test and sympathetic skin response. So this is a thing. So so this is the summary of the grasp of the topic. So the main thing we have to think is like we have to first thing we have to. So next I'll be telling about some case examples. So just like questions. So someone 52-year-old man with hypertension for 10 years, diabetes for 6 years, presented 6 months of burning paresthesia in both hands and feet. There's no weakness. So on examination here, there is no weakness or gait imbalance. There's autonomic. There is no significant autonomic symptoms except for constipation. The patient shows an examination he has decreased pain and touch in the glow and stalking pattern distribution with a diminished angle with otherwise normal motor and gait findings. So this is the
There no motor symptoms except constipation. It's their examination, so patient touch first diabetes hypoglycemia. This neuropathy burning test. And also, but also decrease pain and time. So also the antigen so can use so small.
Small fiber because you don't have a vibration in the joints. You should always look at the vibration and the benefits. That's also sensitive usually whenever you have a abstract reflection. Learning anesthesia can be seen in small fiber as well as large fiber. That is not a unique feature for small fiber. The small fiber by that present for a very common blood transfusion in the absence of other blood transfusions. But large fiber neuropathy or the early stage can present in one transfusion. Or point that they don't have a joint question since all the time question is absent. You should mention that it is no. So in that case, you have to consider it a small fiber. But given that the amputate is also on the lower side, can still be as big.
Ah. So, so this is the case history, and next I will show the nerve conduction study of the patient. Motor nerve conduction study.
Both need.
Hmm. Is there anything abnormal here?
Which part do you prefer? Anything like the right?
Peroneal amplitude.
Okay, what about peroneal amputate?
Reduced.
It's reduced in the right peroneal. If peroneal is like. Okay, so left peroneal looks normal, relatively normal, at least 1.5, right is low. Okay, anything else?
We can conclude here. We can conclude on
We can.
online. We can conclude. So this is the question session. So we are coming to the end of the session, and then rest is like only just questions. So thank you for your patient listening. Thank you for your patient listening. We'll conclude the session here.
From bilateral mediation.
Whenever you have a neural, you always go to the medium.